Hey everyone, welcome back to The Explainer. So let's just dive right into this anime-style tactical review. Now, if you're an MRCP aspirant, you already know that clinical hematology and oncology can feel kind of like a massive, grueling final boss fight. But today, we're going to conquer those high-yield clinical facts together. We are stripping away all the fluff and focusing exclusively on the most testable, absolutely crucial data points you need to secure your victory. So grab your notes, get comfortable, and let's jump straight into the action.
95%. Think about that number for a second. In over 95% of chronic myeloid leukemia patients, you're going to encounter one specific, highly testable genetic fusion. When you see a patient presenting with certain classic symptoms on the exam, this percentage is your immediate anchor. It's the defining signature of our first major topic, and a statistic the examiners just absolutely love to test.
Okay, here is our agenda, our battle map for today. 1. Malignancies. 2. Coagulation crises. 3. The cytotoxic arsenal. And 4. High-yield rapid-fire. Let's get right to it.
Section 1. Hematological malignancies. The first boss encounters. All right, our first boss is CML. Imagine chromosome 9 and chromosome 22 fusing together, almost like two anime heroes merging to create this powerful glowing aura. Well, that is your Philadelphia chromosome, the T922 translocation. This fusion creates the BCR-ABL protein, which literally unleashes excessive tyrosine kinase activity in the body. Clinically speaking, you're usually looking for a patient aged around 60 to 70, presenting with lethargy from anemia, some weight loss, and a massive spleen that's causing them abdominal discomfort. On their labs, watch out for increased granulocytes, but crucially, and mark this down, a decreased leukocyte alkaline phosphatase. And be on high alert here because this condition is highly unstable. Actually, 80% of these cases will eventually transform into acute myeloid leukemia and the remaining 20% into acute lymphoblastic leukemia.
So, what's your first-line special move to counter this excessive kinase activity? You've got to neutralize that BCR-ABL fusion protein's power. Your weapon of choice? Imatinib. It's a targeted tyrosine kinase inhibitor, and it is the absolute gold standard first-line treatment you need to select on your MRCP exam. No hesitation. Moving over to Hodgkin's lymphoma, your primary microscopic target is the Reed-Sternberg cell. If you're looking down a microscope or, reading a histology report and a clinical vignette, you are hunting for these massive cells with characteristic owl eye nuclei. Finding themselves the mystery instantly, you are definitively dealing with Hodgkin's lymphoma.
But what does this actually look like in the clinic? Well, your patient will typically present with asymmetrical, painless lymph nodes, very often in the cervical region. A highly specific, exam-favorite symptom to look out for is alcohol-induced pain in those exact lymph nodes. Watch out for the 25% of patients who present with B symptoms, so that's weight loss, fever, and night sweats. If you see those, it signals a poorer prognosis. On the flip side, if the biopsy shows the nodular sclerosing subtype, you can breathe a little easier. It's the most common type, and it carries a generally good prognosis. As for treatment staged using the Ann Arbor system, your standard management utilizes the ABVD regime. But remember, the battle isn't over after remission. You absolutely must actively monitor survivors for secondary solid tumors, particularly of the breast and lung.
Let's keep moving. Section 2, Coagulation and Clotting Crises, System Overloads. Listen up, because this is exactly what will trap you on the exam. The 2020 NICE update completely changed the battlefield for DVT. Step 1 is always calculate the two-level Wells score. If the DVT is deemed likely, meaning a score of 2 or higher, the algorithm demands a proximal leg vein ultrasound within 4 hours. If it's unlikely, at 1 or less, you move to an age-adjusted D-dimer for patients over 50. But the biggest shift here is in the treatment phase. Direct oral anticoagulants, or DOACs like apixaban, are now your absolute first-line defense for at least 3 months. And here's the real kicker. This applies even for patients with active cancer.
Oh, and you've got to remember this vital extension protocol. If the venous thromboembolism encounter was totally unprovoked, you must assess their bleeding risk using the Orbit score. If that risk comes back low, you don't just stop at 3 months. Nope, you extend that DOAC treatment to a full 6 months. Seriously, do not let the examiners catch you stopping treatment too early on an unprovoked clot.
Okay, let's shift from localized clots to a total system overload. Disseminated intravascular coagulation, or DIC. Imagine a broken dam just rapidly flooding a valley. DIC is a chaotic cascade where both coagulation and fibrinolysis become completely dysregulated. The main trigger, a massive release of tissue factor. This usually happens secondary to severe sepsis, major trauma affecting the lungs, brain or placenta, or an underlying malignancy.
It results in widespread, simultaneous clotting and bleeding all over the body. So how do you spot this system crash on a lab report? Basically, your diagnostic heads-up display will be flashing red. You'll see low platelets and low fibrinogen. Why? Because they're being entirely consumed by the rampant clotting. Because those clotting factors are depleted, you're going to see prolonged PT and APTT. Meanwhile, the body is desperately trying to break down these clots, which leads to dangerously high fibrin degradation products, or FDPs. Finally, look at the blood film. You'll see schistocytes. Those are basically fragmented red blood cells that got sheared apart by the microscopic clots choking up the blood vessels.
Let's see how this builds into another temperature-sensitive crisis, cryoglobulinemia, or what I like to call the reversible freeze. These are immunoglobulins that literally precipitate and crystallize at 4 degrees Celsius, and then dissolve when warmed back to body temperature at 37 degrees. You definitely need to know the 3 types. Type 1 is monoclonal, linked to myeloma and Waldenstrom's, often presenting with Raynaud's. Type 2 is your mixed type, and listen, this is highly testable. It is strongly linked to hepatitis C and rheumatoid factor. Keep that in mind. Type 3 is polyclonal, associated with rheumatoid arthritis and Sjogren's. Clinically, watch for vascular purpura, distal ulceration, and diffuse glomerulonephritis. To win this particular fight, you must treat the underlying cause, though plasmapheresis or immunosuppression might be needed in the short term.
All right, let's switch gears. Section 3, the cytotoxic arsenal, the item shop.
As a physician, you need to master your cytotoxic weapons, but more importantly for the MRCP, you've got to memorize their specific toxic debuffs. Here is the first half of your high-yield cheat sheet. Notice cyclophosphamide. It's an alkylating agent that cross-links DNA. Its major toxic debuff, hemorrhagic cystitis, and a risk of transitional cell carcinoma. You must counter its toxic metabolite, acrolein, using mesna and really aggressive hydration. Next up is bleomycin, an anti-tumor antibiotic famous for causing lung fibrosis. And then we have the anthracyclines like doxorubicin. Their defining toxic debuff is severe cardiomyopathy. You should absolutely always check an echo before prescribing these. Continuing through the arsenal, methotrexate targets and inhibits dihydrofolate reductase, but it causes heavy myelosuppression and fibrosis in both the liver and the lungs. Vincristine, which is a microtubule inhibitor, attacks the nerves. It causes peripheral neuropathy and paralytic ileus. Finally, cisplatin, the platinum-based crosslinker. For this one, you require strict monitoring for ototoxicity, peripheral neuropathy, and severe hypomagnesemia. Seriously, memorize these pairings. They are practically guaranteed marks on the exam. We are in the home stretch. Section 4, high-yield rapid fire, the lightning round. 0 to 4. Think fast. What does this scale represent? It's the ECOG score. It's a vital, standard stat for measuring a patient's functional status. 0 means they are fully active and asymptomatic, while 4 means they're completely disabled and bedbound. Knowing this scale helps you accurately assess a patient's baseline before you launch into any heavy therapies. Moving on to inherited conditions, you need to lock these 2 in. Factor V Leiden is your most common inherited thrombophilia, driven by activated protein C resistance. Crucially, no routine VTE screening is recommended for it. Then there's hereditary angioedema, an autosomal dominant C1 inhibitor deficiency. Your best screening tool here is a low C4 level. These patients suffer dangerous, uncontrolled bradykinin surges causing severe edema. You treat this with C1 inhibitor concentrate. And here's the trap they will set for you. It absolutely will not respond to adrenaline. Don't fall for it. When differentiating hemolytic presentations, just use this direct comparison. G6PD deficiency is X-linked recessive, it's common in Mediterranean and African descent, and triggered by oxidative stress, like fava beans or the drug primaquine. On the blood film, look for Heinz bodies and bite cells indicating intravascular hemolysis. Contrast that directly with hereditary spherocytosis. That features an autosomal dominant inheritance pattern and simply shows spherocytes on the film. Know the inheritance, know the film, get the points. Simple as that.
All right, as we wrap up today's explainer, I'm going to leave you with this boss-level question to test your recall. If your patient requires a cytotoxic special move that inhibits dihydrofolate reductase, which specific organ debuffs must you relentlessly monitor? Think back to our item shop. You got it? That drug is methotrexate, and you better be relentlessly watching their bone marrow, liver, and lungs. Keep revising these high-yield facts, stay focused, and I'll see you in the next explainer. Happy studying and good luck conquering your MRCP.